Welcome back everyone to the COVID Cases Learning. So this is the fourth session in the series for all our junior doctors, staff grades and consultants. And again, we're welcoming colleagues from West London, North East London and Norfolk and Suffolk NHS Foundation Trust. We're grateful to all of you for your companionship in joining us to learn together. As usual, we want you to join the conversation in the chat box. Remember to share your comments with all attendees. And we'll aim to leave some time at the end for Dr. Galuli to check in with us. So there have been many complex cases in the liaison setting in the last few weeks. And in today's session, we tried to draw out some of the key points, particularly around capacity assessment in relation to coronavirus. Thanks to our expert reviewers, Ian Hall, Francesco Maffia, Amanda Popiel, Peter Byrne, Nuala Kane, Johanna Turner, Hugh Grant-Peterkin and Chloe Beale. Most of all, again, huge thanks to Kate Bailey and Lindsay McAlpine for drawing together all the ideas and the key updates in this presentation. Over to you guys.
All the ideas. Wow. Okay. So as we say normally, should we introduce ourselves?
Yeah, we probably should. Yeah. 4 weeks in, we should thinking about that.
I'm Kate.
And Lindsay.
Okay. So in terms of drawing together all the information, I think as we have come to say each week, do kind of share with us your thoughts as we're going through, but also get in touch with us at the end via email if there's kind of updates that you've seen that we haven't seen, because as you're all aware, there's a huge amount of information at the moment. If possible, if you can send us references, that's always really appreciated. So onward, how do I make it go again? Okay. So this is just our weekly reminder from Jonathan Tomlinson, who's a Hackney GP. I think this tweet, although it's a couple of weeks old now, actually still holds true. And just to bear that in mind. So none of this is set in stone, but hopefully we're giving you some key principles that will help. So updates from last week, as you're aware, we talked about a kind of end of life case. ELFT have now got some kind of guidelines in this flowchart, so you can find those through the links in the slides and on the intranet. There's also been some end of life webinars which are available to watch as well. So the rolling agenda item of resus, aerosol generating things and PPE remains, although we're expecting an update on that fairly soon. But I think this meme reg meme captures it quite well. So I won't say necessarily anything more about that, except that the guidance is still sort of a bit conflicting in that we've got Resus Council, WHO and ELFT saying that we should really be wearing aerosol generating PPE prior to starting any resuscitation. But as I said, we're expecting some more updates regarding that fairly soon. So the links are all there, but again, things could change. So NHS England have now issued some visitor guidance as well, which is quite pertinent to last week's case, where we talked about visiting at the end of life, but also importantly for us, looking after people with other mental health issues as well, is that if you're supporting someone with a mental health issue, there's the potential to have a family member present if it's likely to help kind of with the care of that person, so quite relevant for our population as well. So on to the first case. We're doing 2 cases this week, just because we like to pack as much in as we can, like any good on-call shift. So this week we're back working nights as the SHO, and you've been urgently called to see Mr. J, who's a 45-year-old man with mild LD and schizophrenia. And he has tested positive for COVID after spiking a fever 5 days ago, and he's been nursed on the COVID ward since that time. So he's been increasingly breathless over the day, and now he has SATs of 80% on room air. I'm sorry, we always seem to start with a kind of emergency, but it's always good to remind ourselves how we deal with this now, as I'm sure you're growing in confidence. So what are your next steps with Mr. J? Feel free to text in your ideas.
All right, lots of people seeing PPE and ABCDE. Some people suggesting oxygen straight away.
Yep, and a suggestion to call an ambulance as well. So just a reminder to make sure you're responding to all panelists and attendees so everyone can see your answers. So generally we're thinking that we need to get some emergency help for him, but making sure that we don our PPE before entering as well. Good point, asking for all observations and news, which we have been using each week. So the full set of observations are these. So he's got respiratory rate of 24, blood pressure of 110/60. He's febrile, he's tachycardic, but he's still alert. So that allows us then to calculate a full news. So we're getting an 8 when we put all of these onto the news chart. If we didn't already think that we were worried about him, this obviously makes us more worried, and also gives us a way of communicating with emergency services potentially. So we decide to call for an ambulance or emergency response. Obviously that's variable depending on whether you're in a hospital where you would call an ambulance or whether you'd call for a kind of medical response team. So the nurses who are on the ward are of course already wearing PPE, so they've put some oxygen on him and his SATs come up to about 95%, and the observations are repeated, but he's still tachycardic, still has a high respiratory rate. So by that time you've managed to safely don your PPE, and you can observe that he's got increased work of breathing. He looks quite tremulous, maybe having rigors, but he's not really talking to you. So you speak to the med-reg and they accept the patient. They say, yep, definitely sounds appropriate for transfer. Call A&E and let them know that the patient's coming with an escort, and can you please send a treatment summary with current medication and so on. So you review the notes. So if you're transferring someone in an emergency, what are the kind of things that you would want to include in a transfer summary?
Yeah, so we're getting some suggestions about a full list of his medications, his most recent OBS, some information about his comorbidities as well, and a couple of people suggesting that we include information about his risk history too, allergies, medical history, yeah, current medication, resus status, yeah.
Yep,
Lots of good
definitely.
suggestions coming in.
So helpful if we've had discussions about that already. It's all right, just kidding. So just to give us the background, you're scanning through the notes and you find out, as we said before, he's 45, he's got mild LD and paranoid schizophrenia. He's been in inpatient since December 2019 under Section 3. And he was actually going to try and get home this week to his supported accommodation, but he then tested positive for COVID and wasn't able to go. He was mentally really well, approaching discharge, and then he started to refuse medication and have poor oral intake and was increasingly paranoid. He's got multiple admissions under Section 3 previously. When he's not well, he gets paranoid, his voices can be verbally aggressive. He's got type 2 diabetes, hyperlipidemia, no allergies. He's on olanzapine, he's on metformin and atorvastatin, but he hasn't been taking his medication for the last couple of days. And I think just some really helpful ideas coming through as well about kind of communication passports.
List of reasonable adjustments. Some people suggesting that we inform the liaison LD nurses of the transfer, which is a really sensible idea.
Yeah, definitely. And any tips on communication as well. So yeah. So he doesn't drink, he's an ex-smoker, hasn't used substances for many years. As we said, usually lives in supported accommodation or with accommodation with floating support, usually manages his own meds. And he's had lots of capacity assessments for accommodation and finances in the past, which have been documented by the CMHT. Obviously, that doesn't necessarily mean, anything for his medical treatment, but we have an idea that with the right support, the team have felt that he's got capacity for some decisions when he's well. So that gives us some idea, particularly even about the adjustments that might need to be made. And he's visited weekly by his older sister, who's his next of kin, and no parents are living anymore. So on this admission, he was in PQ initially and was quite aggressive, but he hasn't been aggressive since January 2020. No recent history of self-harm, and there hasn't really been any discussion about treatment escalation plans or DNA CPRs for him. So you call A&E just to give them the heads up that you're sending this man over, but you get onto the A&E SHO who says, look, we're really busy tonight, and last night you sent someone over who didn't have a nurse and no handover. So do you really need to send this person? It doesn't sound like he's going to be for escalation to critical care anyway. What's his clinical frailty score? So what do you think about that? Or how would you respond to the A&E SHO?
So a few people pointing out that CFS is not appropriate in this situation, and some people questioning why he wouldn't be considered for CCU.
Yeah, definitely. So that's, and just to remember, I've preempted our what now conversation. Anyway, he's stable, but he's still not well. So advocate for the patient, definitely. So just a reminder again about kind of the criteria for admission or transfer. So had he made it to ED and his SATs were less than 94 or news greater than 3, then he would have gone down the kind of admission route, had investigations and so on. So this NHS England flowchart would suggest that had he turned up to A&E right now, he would have been admitted. Again, just looking at the NICE guidelines as well, that takes into account all the different kind of factors when you're thinking about admission, but obviously very importantly for us is about what can be offered in the current setting of care. And as someone's pointing out in the comments, someone who's gone 15 litres of oxygen to maintain SATs of 95, whilst we've obviously boosted our oxygen supplies, that's not a particularly sustainable kind of plan. And of course, there's other things that can happen on a medical ward that we can't do here. Further investigations, blood gases, IV fluids, all that sort of thing. So there's still, at the very least, a need for ward-based care. And just a reminder again about other ways of assessing severity. But as you guys have pointed out as well, the CFS is not appropriate for people under 65 or patients of any age with stable long-term disabilities. So that's one of the things that's kind of been a highlight of the change in the guidelines recently, because there were some concerns about applying the CFS to people who had kind of stable LD, and it certainly doesn't assess them appropriately because it's meant for frailty and frailty associated with aging. So as we can see from this, the frailty score is something that gets calculated on admission anyway, so it doesn't have anything to do with decisions about access to care in the first instance. And then actually for someone who's got who's under 65, who has LD and other mental health problems, it would be a personalised frailty assessment. And as if we needed any more argument for this, we've also had this letter from Claire Murdoch and other colleagues, really just highlighting the importance of making personalised decisions regarding people with LD and autism, and consulting with their family and carers, and that really there shouldn't be denying of access to treatment because of a learning disability or autism alone. And some tips more recently as well from an NHS England clinical guideline specifically related to LD and autism during coronavirus. So firstly, beware of diagnostic overshadowing, which is something we'll talk about a little bit more later, remembering to have healthcare passports, listening to patients and carers, making reasonable adjustments, and these other suggestions. And I think the other thing is that there's also very high rates of respiratory illness in people with LD. So this is a disease that's going to affect that population. So we need to be very vigilant about that. So you speak to your SPR, who offers to call A&E again to say their concerns and so on, and they manage to get through to A&E, and they speak to the consultant and they say, yeah, no, that sounds quite appropriate. Please can you send him over with a one-to-one nurse and a summary. And just a side note to remember to consider leave arrangements as well for section patients. Best practice is to actually notify the consultant, but whether or not we do in the middle of the night, yeah, anyway, no comment. Some people already have medical leave kind of documented in place anyway. So he's transferred to A&E, you notify his sister by phone, And then at about 1 a.m, you get a call from the psych nurse who's his one-to-one on the medical ward. And she's quite worried because he's very paranoid, and he's saying the nurses are trying to kill him, and he's pulling his oxygen off and trying to remove his IV line. And the nurse has spoken to the medical SHO, who thinks maybe he should just be transferred back to the psych ward. And she puts the medical SHO on the phone, and he says, doesn't look like Mr. J is going to really tolerate this treatment anyway, and it's not in his best interests. So what are your thoughts about this statement? I feel like it's a shame that that one was only sent to us. Someone just wrote wrong. Yeah.
So lots of people questioning why is it not in his best interest, and asking whether the medical SHO has actually done a capacity assessment at this point. Yeah, lots of people just saying why not in his best interests, and trying to get the medical SHO to justify that decision.
Yeah, so I think I think what we tend to see as well is that the idea of best interests can sometimes be used as a kind of turn of phrase when it also does have specific kind of legal meaning as well. So there's a sense sometimes that if someone's having difficulty managing medical treatment, that it might be easier for them to not have access to that. But obviously that's something that we need to kind of try and challenge, but also to support our medical colleagues in helping to care for people as well. So generally we're thinking that it's not the kind of route that we want to go down at the moment. So we have to think about how we're going to kind of manage this. So just a reminder that essentially, you know, this is from the kind of Mental Capacity Act. Firstly, we kind of do assume to have capacity unless it's established that someone doesn't have capacity, but that we also have to kind of take all practicable steps to help someone, and that even if someone lacks capacity, something that is done to them must be in their best interest, and that's very specifically their best interests, not what's easier for us or other patients around them. So in other words, capacity before best interests, and before capacity assessment even, actually actions to support capacity. Are there any reasons to suggest that he might lack capacity though? So I think some people had suggested before that he was probably hypoxic, he was potentially delirious, he's actually not had his antipsychotic medication for a few nights.
Any other reasons, any other things that could be affecting his capacity right now? Yeah, new environment, nighttime.
Yeah, definitely.
Yeah.
So all of these things are probably going to make it very difficult for him to accept medical treatment, not least in which, as we talked about in previous weeks, you know, everyone wearing masks and stuff as well. If you already have kind of problems with communication, not being able to see anyone's facial expression kind of only makes it worse. So these were the kind of reasons that we thought of. And so what can be done? So I think we've talked a little bit about this. People have mentioned kind of trying to support the medical SHO, which I completely agree is very much our role, to try and help them make the reasonable adjustments. So if anyone has any other suggestions on how we can support him.
So we're getting a suggestion through about getting his sister involved, getting her on the phone to help out with this.
Definitely. So if there's any existing kind of communication tactics or things that we know have helped him in the past.
So if not his sister, then a carer from his accommodation might be someone that could be helpful here. And we did get a suggestion earlier about getting an LD nurse, liaison nurse involved, which might be difficult in the middle of the night, but yeah, is a good suggestion as well.
Definitely. Absolutely. So a few ideas. So as with anyone who's stressed and frightened, kind of simple explanations, demonstrations, that's obviously increasingly difficult as well. But if you were needing to get someone to put oxygen on and they were really paranoid about it, you could kind of put a oxygen thing over your face and show them that you're not kind of dying by putting it on. Again, that's obviously impeded by you already having a mask on, but you know, actually showing people that something's safe can be helpful. Again, you know, if it was within office hours, you could ask the LD nurse or the care coordinator to help with some ideas about communication strategies. There's a whole load of kind of more simple information specifically about COVID as well, that has been made for people with LD. So there's some great resources online now as well. But in the acute sense, actually, maybe he just needs some medication because he's, you know, potentially deteriorating both in terms of kind of his kind of potential delirium, but also he's not had his antipsychotics regularly. So possibly giving him some olanzapine orally, ideally, obviously, but if he's not able to take it orally, it might be appropriate to give him something IM if he's very distressed. You can speak to the medics about kind of what's safe to give. As we've said, we've got the NAPIQ guidelines about using kind of sedating medications in the context of COVID and delirium. Obviously, we tend to try and avoid benzos in delirium, but for short-term use, sometimes for the facilitation of kind of investigations or treatment, they can be appropriate. And again, using short-term or short-acting agents instead.
Or rather ones with a short half-life rather than short-acting to minimise the risk of any respiratory depression if they deteriorate.
Yeah, definitely. And another kind of cautionary aspect is that you know, there's the potential also for accumulation of antipsychotics and benzos in the context of dehydration. So that's the kind of balance that we need to strike, as we've mentioned. And inflammatory states can also increase the permeability of the blood-brain barrier, so also risk of increased side effects and so on. He's got a one-to-one nurse, but is there a potential that he could have 2-to-1 if he was needing it, and also getting support from his sister by phone. So he actually then speaks to his sister and he takes some oral olanzapine and he calms down quite a bit, and he's keeping his IV line in, his oxygen on, and everyone's kind of breathed a sigh of relief. So that fire has been put out temporarily, but of course, you know, something else is coming. But before that, do you have something to add?
No, I think that probably covers it there.
Okay, so I know we said we might mention diagnostic overshadowing, and it's just something that's kind of worth being aware of. You're probably familiar with the term, and it did originally come from the idea that clinicians might attribute symptoms or behaviours of a person with LD to underlying LD rather than kind of diagnosing a new depression or something like that. But it's increasingly being used to describe the kind of how a mental health diagnosis might create a bias or prejudice in the interpretation of symptoms. And there's also issues of kind of treatment and access to treatment. So, you know, studies have found that people who have mental health disorders are sometimes offered a different kind of treatment option from those who've not got mental disorders when it comes to kind of decisions about admission for a diabetic crisis or cardiac interventions and that sort of thing, because there's a kind of presumption on the part of the clinician that they won't engage in the treatment well. So this is something that we need to be aware of. And I suppose what it also can manifest in is people attributing new kind of psychiatric symptoms to an underlying psychiatric condition, when in fact a delirium could be the kind of thing that's happening. So you've kind of sorted that situation out, but then you get a 4 a.m. call from the MedReg and they say, can you please come to the COVID ward? We've got someone who's refusing intubation and she's deteriorating, but we're not sure if she's got capacity. She's got a history of mental health problems and she seems a bit psychotic. What are your initial thoughts about this?
All right, so a couple of comments coming in around this. People sort of saying that perhaps it's the MedReg's role to assess capacity here. And Yeah, I mean, some comments saying that it sounds like maybe the medics are just really struggling with time, and that's why they're bombarding us with phone calls on this night shift. But yeah, the consensus here seems to be think about giving phone advice and get more information from the medics and ask them to assess the capacity themselves.
Yeah, so that's generally how we kind of approached it. So firstly, it's kind of how urgent is it, and what are we talking about the capacity, because obviously it's decision specific, but also importantly kind of what steps have they taken to optimize her decision making, and those are the kind of things that are kind of enshrined in the Mental Capacity Act about sort of, you know, adequately explaining things, but also making sure that you're, you know, that people have hearing aids, and you know that you're speaking in the right language for them and all that sort of thing. And you know, and do they have concerns about her mental state? Because actually, if her mental state is affecting her decision-making capacity, that may well be a situation where we should be involved. And also just to get an impression from them about what their assessment is, because it is important that they at least try and make a first attempt, so that then we can come in and offer some support after that. So we thought generally that actually you would probably agree to see her, but with quite a clear remit in mind, and potentially discussing with seniors prior to seeing her. The reason for that being that, you know, you're probably going to then don your PPE. So having a bit of a framework in mind if you're not quite sure what questions you want to ask, rather than having to kind of duck in and out of PPE, might be helpful to have a conversation before you go, and then again after you've seen her. Do you have anything else?
No, I suppose we're getting more comments through just saying that the medics need to have the opinion themselves, but you know, querying whether it's reasonable for them to get advice and support and a second opinion from us as psychiatrists, and pointing out that probably it's not helpful to get into a debate at 4 in the morning about whose job it is to assess capacity. Yeah, especially since the medics really need support here.
Yeah, and I think the other thing is that often requests for a capacity assessment can be asking for help in managing a patient, but not necessarily through that route. So I completely agree that, you know, it is about overall support, not just capacity legislation. So from the code of practice, you know, it talks about kind of emergency medical situations where decisions have to be made in someone's best interests, and you kind of need to take immediate action, and it's not appropriate to delay the decision. Of course, this is one of those situations that's kind of potentially difficult because the person hasn't actually collapsed, they're not kind of unconscious. So there's potentially, it's in that kind of grey area where some urgent treatment is probably needed, but there probably is time to kind of assess things a bit further. But again, it is a kind of grey area. And an exception to the rule of kind of giving treatment would be if you were aware that there was an advanced decision to refuse treatment. That's the kind of situation where you would kind of get into difficulty. So the role of psychiatry in this situation is potentially to assess mental state, identify if psychopathology is impacting on this woman's decision making, but specifically, should we assess capacity? What do people think about that?
So I think some very fair points that a bit of joint working can remind people that the patient's at the centre of all of this. And yeah, it seems to be a lot of people suggesting a joint assessment might be the constructive thing to do here.
Yeah. So we can provide advice in terms of the legislation around capacity assessment. This is very specific to capacity assessments. We can provide advice and assistance to the decision maker, who is in this case the MedReg. And this is from the code of practice that the decision maker can get professional opinions, but actually the final decision rests with them. Or if they feel like they're unable to make that decision, then they have to escalate it through their own kind of legal departments and so on. But the decision is ultimately up to them, but we would be providing them with kind of expert advice as people who treat and assess mental disorders. So this woman, Mrs. B, 52-year-old Bengali woman, she self-presented to ED 5 days ago with a fever and a cough, worsening short of breath for the past 48 hours, and that was very typical of a COVID infection. So she had SATs on room air of 89 when she first arrived, did well with only 2 litres of oxygen initially, but she did have quite a high CRP when she first arrived, and she was admitted under the medics, and a full escalation plan was documented on admission, and no documentation of advanced decisions to refuse treatment. In terms of her past mental health history, so she had an episode of psychotic depression 5 years ago after the death of her husband, and she was admitted on a Section 2 because she was physically neglecting herself and had nihilistic delusions. When she was unwell, she heard the voice of her deceased husband telling her that she was going to die and join him, but she didn't have any active suicidal ideation of her own accord, and she recovered quite quickly, returned home and was under the CMHT for 2 years, and then discharged back to her GP. And she's been on olanzapine and sertraline since that time. And she's got type 2 diabetes, and she's the primary carer for her son, who has moderate LD, and he's now being cared for by his sister. So on the medical ward, she had initially about 3 litres of oxygen requirement. She was confirmed COVID positive, again managing on 3 litres with a plan for wean. She was stable again, with the hope of being discharged soon, but she's then on day 5, which is today, or earlier today, she desaturated to 85% on 15 litres. She's got a new renal impairment on bloods, CRP is going up again, and she's been commenced on IV antibiotics. So, and throughout the admission, the other thing to note is that she's been quite cooperative with everything, no real concerns raised about her mental state. So at 3 this morning, she's reviewed by ITU. They explained to her that she's been very unwell, and they don't think she can manage her oxygen requirements without ventilation. And she's just saying no, 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 and kind of pushing nurses away and refusing to discuss anything. She's not really managing on CPAP and in a prone position. There's a Bengali nurse there, and she says she's not really making any sense. So just a reminder that, and I'm sure you know this already, decision-making capacity is decision and time specific. And there is a presumption of capacity, although I guess I would say that by the time it comes to us for a second opinion, we have to go with a kind of blank slate, but we are looking for kind of any mental disorder that might be affecting someone's decision-making capacity. So it's, I suppose, more likely that people may have trouble with capacity by the time they get to us, but we still need to try and have a kind of unbiased assessment. It is for us to prove an absence of capacity, and not engaging is not a kind of sufficient evidence to say that someone lacks capacity. And again, we're going to come back to this idea of the causative nexus, which is meaning that if there's a lack of decision-making capacity, there has to be an underlying kind of reason that we're able to draw to. And the important fact about that, I suppose, is though that the impairment doesn't need to be a diagnosable psychiatric condition. So it doesn't have to be something within the ICD-10 or the DSM. It can be something slightly more vague. So the important thing though is that what information needs to be provided to someone before their capacity can actually be assessed. And this is related to kind of giving informed consent, which of course you'll also all be aware of. And this comes from the BMA consent toolkit. So it's kind of broadly their purpose or investigation, uncertainties, options for treatment, including the option of no treatment, and what are the likely benefits and probabilities of success or consequences for those, and the risks. And all of these other things that you or I would all want to know before we were kind of consenting to something. So they talk about a 3-stage capacity test, and that's firstly the functional test. So can you make a decision specific to this? The diagnostic, as we said, is there an impairment of or disturbance in functioning of mind or brain? Although it's called the diagnostic, you don't have to name a specific diagnosis. Obviously, if there is a diagnosis, then you would want to make that call. And the causative nexus being is the person's inability to make the decision because of the identified impairment or disturbance. And cases that have gone to kind of court of protection and things, if people haven't made that link, you know, that it's not acceptable as a capacity assessment to kind of suggest that someone lacks capacity if there's not that causative nexus identified. So this is kind of the wording in the actual Mental Capacity Act, which is with kind of, you know, I think we've kind of explained it pretty well, but I guess importantly, you will see the kind of the three-stage capacity test is sometimes in a different order, where people will say that the impairment of mind or brain is first, and then the functional test after that, and that's how it is in the code of practice. The one from here, so this guide to assessing capacity from the 39 Essex Chambers, which is a law firm that's specifically focused on the Mental Capacity Act, make the argument that really the functional test should come first, as it's described in the original Mental Capacity Act, to avoid kind of stigma and kind of bias pervading capacity assessments. Because if we look at the diagnostic test first, that might kind of predispose us to thinking that someone lacks capacity because they have a mental disorder. In practice, of course, we're kind of thinking about all of these things at the same time, but it's helpful to try and have our thoughts in an ordered fashion. So these are the elements of the functional test, and a reminder that you only need to not be able to do one of these things to not have capacity. So it's not that you have to kind of fail on all accounts. If you can't do one of those things, then you do lack capacity with regards to that decision. And then, of course, the disturbance of functioning can be due to any of these things, and I suppose particularly relevant for our group or the population we might be seeing at the moment, particularly related to COVID, are kind of delirium, hypoxia, hypercapnia, uremia or liver disease. So there could be kind of temporary physiological abnormalities that will affect people's decision-making capacity in a hopefully temporary way. So general tips, I suppose, although it is a structured assessment, it's a bit like the mental state, because it's still a conversation that you're having with someone, and you're kind of giving them information and they're giving information back to you, or you're with someone who's giving them information and you're kind of discussing it with that person, because you're trying to understand someone's decision-making process. People advise against using closed questions, because if you say to someone, well, do you understand the treatment? And they say yes, that doesn't really tell you very much about how much they understand. And understanding the person's background is important to understanding their kind of beliefs and values, because, you know, we're asked to actually look at how they use their beliefs and values in making a decision, and we're asked to assess how they're doing that. So we need to understand those before we can do it. Otherwise, we risk kind of imposing our own. And I suppose, but all of this to bear in mind is, you know, in an ideal setting when there's time, and this may not be that setting. So these are the kind of gold standard things to do. There is kind of provision and understanding that, you know, the more emergency the situation is, the less possible it will be to explore all of these things, but you still want to be trying to cover as much as you can. I suppose just I found, particularly in the acute hospital, just asking quite generally about someone's experience of hospital can be quite illuminating. So there's a lot of capacity assessments that come from the kind of end of the tether type situation, where someone's been in hospital for a week, they haven't slept, they haven't had a proper shower, they're in pain. And actually, if you can kind of sort of hear those things, it might be that, you know, this decision to refuse this final thing that they're saying no to is actually kind of a cumulative frustration, and that if you can kind of understand how to treat their pain and that sort of thing, they may be much more amenable to having a discussion about what treatment they will have, and again, sort of how they're feeling right now. And also, I think really, how do people normally make big decisions? So if someone tells you that, you know, they would always discuss with their family before they make any big decision, but they've decided not to in this situation, that doesn't mean they don't have capacity, but it's important to understand why. You know, that could signal coercion, but it could also signal paranoia. It could, you know, it's just about being curious and trying to unpick things as much as you can. So again, just a reminder, of course, you can't really understand something if it hasn't been explained to you. So things do need to be explained in real time at the time that you're seeing someone. You don't need, patients don't need to believe clinicians in order to have capacity. There's been some kind of case law related to that, although it's quite a difficult grey area as well, because if someone's kind of, you know, it has had a long-standing belief that doctors are just a bit rubbish, and they say this time, well, I don't really think that you know what you're talking about, that kind of makes sense in keeping with their worldview. But if there's someone who's kind of always respected doctors and is suddenly saying, well, I think you're wrong, that might spark a little bit more concern. And again, you know, people don't need to understand kind of every single aspect. They need to understand enough to make the decision. And retaining, of course, is just long enough to make the decision, so it's at the material time. The using and weighing is, again, as we mentioned, to do with the patient's own values, so not ours. So again, it is about trying to understand kind of what's important to that person. Again, a relevant kind of case there as well. And communicate is by kind of any means.
So we're getting a question coming through saying what if they need intubation and they can't speak full sentences, which I think comes back to our slide here, which is that, you know, there's more ways to communicate than just talking, and I suppose you have to try and exhaust every possible option to try and give them every possible chance to communicate with you.
Yeah, although I think as well, you know, hopefully if there's a sense that someone's going to need intubation, you hope that there might have been the beginnings of conversations before the time that they're kind of in acute respiratory distress, but I guess that's an ideal world. If someone's not able to speak in full sentences, it's also fairly likely they're going to be quite hypoxic. Again, we can't assume that they don't have capacity, but that's going to severely limit kind of their ability to do that. And there is, you know, I suppose that is when it potentially becomes emergency kind of treatment. But I think this is the kind of grey areas that we are working in at the moment. So again, the diagnostic test is also still part of the conversation, like mental state examination. You're kind of, you know, talking to a person and understanding what's kind of going on for them. But really important, I think, also in these times to document the physical health status, especially if you're kind of thinking that someone's hypoxic and that might be the reason that they, you know, they don't have capacity, then actually documenting what their oxygen sats at the time might be useful in kind of explaining, and also speaking to the medical team about, you know, is this level of hypoxia potentially impairing them? Because it's also in the context of what they're normally running at as well. So if they're normally a bit hypoxic, it's probably not likely. So you get to speak to her with the med-reg and a Bengali speaking nurse. She's saturating at 90% on 15 litres, and she's really refusing to engage in the information, and she just kind of is turning away and saying, take me home, what is this place, God help me. She's calling for her husband. She looks quite frightened. She's turning her face away. She's pulling at her IV line. She seems to be seeing something on the floor, which she says is snakes, and she's rocking back and forth. And you manage to get her daughter on the phone while she's still in the room, and she says she's never heard her mum like this before. So you then speak to the daughter on her own, and she says that when the pandemic started, her mum was really worried about not being able to look after her son should something happen to her. She's been mentally really well, but she does find hospitals quite frightening because her husband died in ITU, so she's been quite traumatized by that. But she looks after her health really well, and she has usually great respect for doctors. Her daughter's really surprised that she's kind of resisting what's being offered to her. So what do people think in terms of her capacity to decide about ITU admission and intubation?
Any other thoughts on whether or not she has capacity here? All right, so quite a few people pointing out that she likely has delirium here, and people saying that she most likely doesn't have capacity on that basis. Yeah, everyone seems to be on the same page here. Hypoxic and delirious.
Yeah. Okay, so we do think she has an impairment of mind or brain. We think she's probably delirious, and we do think that the delirium is affecting her decision-making capacity. So some people have said snakes may be making her want to leave hospital, delirium potentially affecting her attention, retention of information, and decision-making or ability to kind of use and weigh and hold information in mind. So just a reminder about delirium. It's one of my favourite topics. So just a helpful question if you're trying to call relatives in the middle of the night or asking nurses on medical wards, a single question of, do you think Mrs. B has been more confused or drowsy lately, is quite a sensitive and specific way of picking up delirium. Obviously it only works if people actually know the person, but particularly relevant in this case was that actually she'd been quite fine for all of her kind of treatment up until today. So that would suggest to us that actually it's an acute change in her mental state. It's probably not a relapse of her psychosis. It's much more likely to be a delirium. And we know, of course, also that there's reports of delirium in COVID, and that there are studies showing kind of cognitive deficits associated with acute hypoxia and chronic hypoxia as well. So we thought, no, she probably doesn't have capacity, and actually she's kind of I don't like the word fail. I can't think of a better word. Anyway, she's not managing in any of these areas. She's not even able to consistently communicate a decision at the moment. And we do think she's got a delirium. So in terms of documentation, you want to kind of explain what decisions being assessed, ensure that all the correct information is available, identifying the kind of salient and relevant details. Make sure you document what efforts were taken to promote her ability to decide, and the evidence for each element of your assessment, and why it's an incapacitated decision rather than an unwise one. That's particular for documenting a capacity assessment. The other things, of course, as a liaison person, you're going to want to document is kind of her mental state. You're going to want kind of any kind of history that she's giving you, cognitive assessment, that sort of thing that's going to also evidence the fact that she has a kind of mental disorder. So the MedReg feels she doesn't have capacity to make decisions about her immediate treatment, and does think that probably she is delirious. They ask, is there any role for the Mental Health Act in this situation? What do people think about that? Some small no's, some big no's. Okay, and then some suggestions of MCA rather than MHA. So just moving swiftly on. So essentially this is I don't know if this is helpful or not. At one point I understood it, but essentially there's an area where you can be incapacitous but not refusing treatment, and that's kind of where DOLS, so when they talk about assent rather than consent, that means that you're not kind of refusing or kind of resisting treatment, or needing kind of restraint, and that's where kind of DOLS is appropriate. Where the Mental Health Act can be used in treating physical health disorders is only where it's kind of part of or ancillary to the treatment to mental disorder. So that can include treating wounds or self-harm. But in terms of the Mental Health Act treating physical health disorders, in delirium it sometimes is used if there's kind of repeated resistance and restraint needed. But generally, you know, if someone's kind of delirious and requiring nursing kind of support and that sort of thing, DOLS would be appropriate. But things have changed again, because there's some new guidance specific to the COVID-19 pandemic, and essentially suggesting that if people are having life-saving treatment for COVID-19, that they are not considered as being deprived of liberty in situations where they may otherwise be considered if it was not a pandemic situation and they were having medical treatment. So things are slightly different. However, if people are receiving psychotropic medication and kind of restraint and any psychiatric treatment, DOLS is probably still sort of appropriate then. Just a reminder about best interest decisions. We really want to take into consideration past wishes and feelings, and current wishes are also not completely irrelevant just because someone lacks capacity. Involving family is important. What's reasonably ascertainable as well also depends on the kind of time of day and who you can get hold of, but still helpful to try and contact people in an emergency if possible. This is the checklist of things to kind of go through, and again involving the MDT is helpful. And So you discuss with her daughter, and she thinks her mum probably would have wanted everything that was offered to her in terms of treatment, and this contributes to a decision that actually she should be for ITU in her best interest. She has a little bit of lorazepam, she tolerates the CPAP a bit longer, but then her stats are dropping and she's sedated and intubated in ITU. So she is there for about 10 days. She's extubated after that time. She doesn't need any further liaison input during her admission. She doesn't remember anything of the last 2 weeks. This is a flash forward, in case people haven't realised. She's able to have some phone calls with her son and daughter. So just the kind of headlines about these kind of situations. Don't feel that you have to make the decision alone. Do speak to your seniors on call. You know, it's very unlikely that if someone's so medically unwell that you can't get a chance to call your SPR just to discuss the situation, then it's unlikely to be a case where you're even going to get there in time to assess the person's capacity. So that's probably more likely to be an emergency situation where the medical team will have to make their best guess of what needs to be done. So I think that there should really be time for us to discuss this with our seniors in an on-call situation. And the other thing is that it isn't actually your decision. So you want to be discussing this with the medical team as well. And the other thing to say is that, you know, people can be impaired in their mind or brain functioning without a specific psychiatric diagnosis. You may not be able to completely fulfill all kind of DSM criteria in the time that you're assessing someone, but you know, you can use your best judgment. In terms of people who can help, we do have some kind of in-house advisors, and they can also then escalate to law firms if there are kind of issues that can't be resolved from their advice, but that would be really accessed via your consultant on call overnight. And acute trust should also have similar mechanisms, so they can raise concerns in a similar way. So as we said, you know, diagnostic overshadowing is something that is going to be quite important for us to be aware of in these times. Shortcuts and kind of those sorts of things are probably going to be more common in resource scarcity, of which we're in at the moment. But we do have a really important role in supporting people who are mentally unwell to receive the treatment that they need. And we do have a role in supporting medical teams in caring for our patients, but also in difficult capacity decisions. And do discuss with your seniors. And we'd just like to thank again those who've supported or advised on the presentation. I should hand over to Paul.
Thanks so much. Yeah, I just want to say thanks again to Kate and Lindsay for an amazing presentation again. Really useful cases. Please do give us your feedback on what's helpful about these sessions. We are going to hand over to Paul now for a little bit of an update, but next week we have a really exciting perinatal case, so that's to look forward to. So can we, if we can unmute Paul?
Yeah, I think I'm unmuted. Thank you, Juliet. Thank you, Kate and Lindsay, as well, for an excellent presentation. I found that really, really useful. It certainly helped me think through some ideas and some challenges that's faced in the front line. Before I start, can I just start by saying a huge thank you to everybody? I think it's real challenging times in the clinical front line at the minute. Obviously with COVID, we see service users with COVID, we see colleagues having COVID, we have that uncertainty if people have COVID or don't have COVID, which makes it very challenging work environment to be in. But not only are you facing a difficult and challenging work environment, it's also on a personal level. We have relatives who might be vulnerable to COVID. We have relatives who are self-isolating. We have neighbours, we have friends. We have a broader sense of that anxiety rather than just our work anxiety. So I just want to say to everyone, thank you for what you're doing for the National Health Service and for everyone at this present time. And just to let you know that from an executive point of view, we really appreciate and acknowledge the challenges that you're facing at this time. I've not got much time to actually go through loads of stuff with you at the minute, so I just thought I'd mention a couple of things. Firstly, PPE, which everybody is the first thing in the tip of everybody's tongue. And Lorraine came last week to talk about PPE. I apologise. After sitting through the whole talk last week, my computer went down, so I wasn't able to talk at the end at all. But PPE, the flow seems much better with PPE, and Lorraine sent out some guidance on PPE last week. From a trust perspective, I think we feel much more confident we've got the stocks we need at the present time. We just have to keep those up. There are some pockets, I acknowledge, where we don't have the PPE that we'd want, and just keep the kind of asking for the PPE when you need it, if you need it, and the type of PPE you particularly need. Guidance will come out today. You will be aware the resus guidance has been reviewed by Public Health England, and there's new resus guidance for all resus cases, and we've got to issue some guidance on that from an health perspective, which should come out today. That will also include, over the next 24 hours, talking about FFP3s, which there should be FFP3s available at the minute, but talking about rolling out a plan for fit testing FFP3s initially in high risk areas, but then subsequently in other areas as we move along. But whilst we're waiting for that fit testing to take place, to actually fit check and how you go about fit checking, so you should receive information on that over the next 48 hours. The other bit is about staff testing. And I know there's an awful lot of anxiety about staff testing and false negatives coming up in staff testing. We're again doing guidance in that, which should be out in the next 48 hours. We're also setting up our own clinic for staff testing. At the present time, we only have the drive-throughs that we're using. I'm aware that some people are unable to drive. So we should start to see an increase in that with the clinics in the next week or so. Lastly, there's been some questions I've noticed has come up about the Nightingale London. You will be aware the Nightingale London has opened up. It now has 19 patients, which is fantastic news because we expected the demand in the Nightingale London to be much higher than that at the present time, which makes us feel that the pandemic is much more under control. Psych liaison advice has been sought. It's not been sought from ELF, but psych liaison input I've heard is going into the Nightingale London, but the plan is for patients at the Nightingale London will be intubated and ventilated, and once stabilised, they will be moved on to the step-down hospitals, which for us is Royal London, where extubation should take place. So actually, the only thing they've asked for us is for some support of their staff at the present time, because obviously I think as the numbers increase, there'll be quite a bit of trauma on the staff. That's all I'm going to say at the minute, but I'm quite happy to take any questions if anybody's got any questions. The prospects of antibody testing, somebody's asking about. My understanding of that is still 2 or 3 weeks off before we get any antibody testing. But antibody testing is actually on its way, but nothing at the moment, I'm afraid. Any other questions? Okay. Is the groups looking at staff support for acute hospitals? Yes. There's groups looking at staff support within the organisation. So look at our staff support first, but then reaching out to other partners and helping other partners within the system looking at staff support. We're not only looking at that from other partners being within the NHS, but also social care partners, particularly nursing homes have come in for a lot of, they're the last ones to get the PPE. They've seen a lot of deaths and a lot of them are struggling. So we're trying to look at how can we help with other partners to help support nursing homes and acute hospitals at the present time as well. Can there be updated guidance sent to nursing staff not to wear PPE as perceived recommended guidance rather than compulsory? I think the guidance at the minute is all nursing staff should be in PPE because it's all face-to-face contact. You should assume everyone has the potential to be positive for COVID, and not only should you be in PPE so that you don't spread to them and they don't spread to you. So I'm a bit confused by that question. Well, if it's not been followed, I'd take it up through your local management. Don't know if there's any further questions because we're going to have to finish off. So again, thank you very much, folks, for all that you're doing at the moment. I'll be here next week again. And thank you again to Juliet, to Lindsay, and to Kate for an excellent presentation. Thank you.